Hello, this is Jennifer Klimek Yingling, and today we're going to discuss an endocrine disorder, diabetes. There are two types of diabetes, type 1 and type 2. Type 1 affects about 5 to 10% of individuals with diabetes and is less common. It often presents in children and in the age less than 30. This is the etiology of type 1 diabetes is basically that there is pancreatic cell beta cell destruction. And because of that, there's no way that the body can make insulin. These patients often will present with diabetic ketoacidosis. And so by the time that it's recognized, there are no beta cells left. Type 2 is the most common type of diabetes, and you're going to see a ton of this in your practice. This is the most common type. About 90% of diabetics have type 2. It's often seen in middle age and older adults. And the etiology of diabetes type 2 is a loss of insulin secretion of the beta cells. They kind of poop out. These patients will present with hyperglycemia. So with diabetes type 2, there's several risk factors that are associated with this disorder. One of the biggest ones is obesity. As the NP, you want to look at the current BMI. Is there a history of childhood obesity? Is there a birth weight history where the individual was more than 9 pounds? You also want to think about the way that the individual's fat distribution is. You think about people who are built like apples, right? Skinny arms and legs, big bellies. Increased waist circumference also is a risk factor for type 2 diabetes. Sedentary lifestyle, family history, increased age. Women also are at risk, higher risk for diabetes type 2. Ethnicities, Asian, Hispanic, and Black Americans. And there also can be drugs that induce diabetes mellitus type 2. Thiazide diuretics, not the best choice for somebody who's in poor glycemic control because they can bump the sugars. Beta blockers. Beta blockers, you need to remember, can mask the signs and symptoms of hypoglycemia, which can be really detrimental for our diabetics if they don't know that their sugars are low. Antipsychotics, often these will cause the patient to gain weight, and then the sugars will climb up. And then people who are taking steroids, that can also increase the sugars. It's important that you know symptoms of hyperglycemia. If you've watched some of my other videos, you'll know that I love mnemonics and I love ways to try to remember, whether it be visual or ways to remember with little words and sayings. So it's an easy one. You probably learned this in your undergraduate nursing. There's the 3 Ps, the polyphagia, where you're eating a lot, polydipsia, where you're drinking a lot, polyuria, where you're going to the bathroom a lot, and there's also glycosuria, where there's sugar in the urine. An individual may have ketones in the urine. They may have a weight loss, blurred vision, weakness. They may tell you that they feel tired all the time. And there's also something called Acanthosis Nigricans. And we'll talk a little bit about that on the next slide. Acanthosis Nigricans. This is can be seen with individuals who have diabetes type 2. It can be also an indication that there is colon cancer, okay, especially in the GI tract. And these are dark, velvety patches of skin that often appear on the armpits, the groin, and the neck. So you may see this on your patient. If you see this on your patient and this may be somebody that it's indicated to get a blood glucose to see what's going on with them. Ketoacidosis is a serious condition, and you want to avoid it if you can with your patients by making sure that they have good glycemic control. But there's some things that can cause DKA or diabetic ketoacidosis. It could be sepsis, surgery. It can be your individual who has missed insulin doses or can't afford the insulin anymore. Stress can exacerbate it, and substances like alcohol and illicit drugs. What are the symptoms? These patients will come in, they will have very high blood sugars. They'll have complain of diuresis, delirium, dizziness, dehydration. They may have small breathing or ketotic breath. That'll be fruity, that insent. They may complain of abdominal pain. How do we diagnose these patients? They will have sugar greater than 250. They will be in ketosis. You're going to get an acetone level. And they'll also appear to be acidotic. So you're going to need to probably get an ABG. And you're going to see that that pH is less than 7.2, which indicates that the anion gap is wide. Disorder is a conglomerate of several disorders that put patients at risk for atherosclerotic cardiovascular disease. And these patients have insulin resistance, diabetes. They often will have vascular neurological complications such as ACVA. So how do we diagnose somebody with metabolic syndrome? They generally have to have 3 or above of the following criteria. We talked earlier about a waist circumference. So an individual with a waist circumference 40 inches in men, 35 in women is a risk factor. Elevated triglycerides of 150 milligrams per deciliter of blood or greater. Reduced HDL, less than 40 in men, less than 50 in women. An elevated fasting glucose of 100 or greater. And blood pressure values of 130/85 or higher. Okay, they have to have 3 of those to meet criteria for metabolic syndrome. And you want to be on the lookout for this because often diabetes will not just stand alone. It'll kind of cohabitate with hypertension, with high triglyceridemia, with cardiovascular disease. One type of diabetes that's important to discuss is gestational diabetes. And we screen all pregnant women between the weeks of 24 and 28. We do an oral glucose tolerance test. If it is greater than or equal to 135, this is considered positive. Who's at risk for gestational diabetes? Somebody who has had a previous episode of gestational diabetes. We know that there's about a 40% risk of recurrence. Family member, especially a first-degree relative that has diabetes, a pre-pregnancy BMI greater than 30, significant or excessive gestational weight gain in the first 24 weeks, older maternal age. We talked about ethnicities that are at risk for diabetes type 2. These are the same individuals who are also at risk for gestational diabetes: Hispanic Americans, Native American, Black Americans, and individuals that may have had polycystic ovarian syndrome, PCOS, a previous birth of an infant that was greater than 9 pounds. And it's important we pay attention to this because there can be several complications. They can have a large baby, 10-pound baby. Nobody wants to push out a 10-pound baby. That's like a watermelon, okay? You need to stop it. So you want to make sure you stay on these sugars with these women. Preeclampsia, gestational hypertension. These patients can have polyhydramniosis and then stillbirth. So it's important we pay attention to gestational diabetes and be vigilant for it for pregnant women. What goes up also can go down, and it's important that we are aware as clinicians what the symptoms of hypoglycemia are, and we also need to educate our patients. So first thing, tachycardia. These patients can have irritability, restlessness, excessive hunger, diaphoresis, and depression. If you have somebody with an acute mental status change, the first thing you need to think about is getting a point of care blood glucose, because hypoglycemia can cause mental status changes in our elderly especially. Diagnosing diabetes, there's a couple things that we look at. We look at pre-diabetes. These are patients that should be big red flags, flashing lights, rainbows, fireworks, everything for the clinician to be vigilant, because there's so many things that we can help our patients get control over, especially when you think about modifiable risk factors. So with the fasting blood glucose, prediabetes is generally in the range of 100 to 125. Diabetes is either equal to or greater than 126. A hemoglobin A1C, prediabetes 5.7 to 6.4. Diabetes is considered greater than or equal to 6.5. They also do 2-hour glucose tolerance test, 140 to 199 for prediabetes, greater than or equal to 200 for a diabetic. And then you have your random plasma glucose. This is greater than 200 with symptoms. Now, if it's greater than 200 and they're asymptomatic, you're going to want to get 2 abnormal tests from the same sample or 2 separate test samples. Now, let's just talk a little bit about hemoglobin A1C. There's some things that can affect the hemoglobin A1C. One is red cell turnover. Okay, you can have a false high hemoglobin A1C, and that can be in disorders that have, very, very high red cell turn, or I'm sorry, that you can have a false A1C when you have a disorder that has when red cell turnover is low. Okay, so you've got a lot of old red cells, and this can happen in individuals that have vitamin B deficiency, your folate deficiency. On the other hand, you can get a falsely low A1C levels in individuals that have a lot of young red cells. Now, this might be somebody who has thalassemia. They may have that G6PD deficiency, okay? This can be also found in patients treated for iron B12 or folate deficiency and patients treated with erythropoietin. So the other thing that's important too is your individuals who have chronic kidney disease, and that's something that we know is another that kind of cohabitates with diabetes, chronic kidney disease. So there can be an inaccuracy as well in the A1Cs with the patients with chronic kidney disease, just because they are getting hemodialysis. They may be getting the erythropoietin. So that can cause a lower A1C that isn't truly what is going on with your patient. Test is an alternative for the hemoglobin A1C, and it is different than the A1C because we know that the hemoglobin A1C looks at a range of about 2 to 3 months, right? Well, the fructosamine test is a much shorter period. It will give you information on the glucose levels over 2 to 3 weeks. Okay, so keep that in mind. Fructosamine, that is an alternative to hemoglobin A1C. We're going to look at glycemia, but it's shorter than the A1C timeline. It'll only be 2 to 3 weeks before the test is drawn. A1Cs, there's some things to consider. We know often if we have an elevated A1C, we're going to start. First line drug is metformin. We want to consider insulin with somebody with an A1C greater than 10 and a fasting blood glucose greater than 250. But there's some individuals we are going to make some, concessions for. So for most individuals, we'd like to see them under 7. We'd like to see them under 6 with non-insulin dependent diabetes and during pregnancy. But if it's somebody who's older or frail, greater than 7 may be acceptable for them because you worry about episodes of hypoglycemia, which would cause a fall, which perhaps could cause a broken hip or a significant head injury. Type 1 and type 2 diabetes, there's several things that need to be evaluated. When you think about these patients, you're going to want to make sure that you're monitoring a hemoglobin A1C. You're going to do that about every 3 months until your patient is under control. Fasting lipid profile, we want to make sure that we're staying on top of any risk factors that we can help modify. Liver function tests, we're going to be checking that urine albumin. Is there any protein in the urine? We're going to be looking at the serum creatinine with GFR. Patients that have diabetes need to have good foot care. They need to see a podiatrist. They need to have an annual exam, eye exam, It's important that they get their immunizations because we know that they can be at risk for sepsis. So you want to make sure you're doing your Tdap, your Hep Bs, your yearly influenza, COVID. With type 1 diabetes, you're also going to make sure that you screen for thyroid disease as well as celiac disease. So you're going to do a TSH and a celiac body antibodies because we know that with type 1, that's an autoimmune. And it's important to make sure that we recognize any comorbidities that may come up. The other thing that's important for diabetics, some considerations, you may want to put them on a low-dose aspirin, especially men over 50 and women over 60, especially if they have an additional coronary artery risk factors such as hypertension, some smoking, family history. You want to make sure their blood pressures are controlled. We talked about monitoring their cholesterol. We want to talk to them about their diet. We want to limit trans fats and saturated fat. You may want to schedule your patient with a dietitian. Dental care is also quite important. You want to reinforce and encourage. You want to encourage these patients to get more than 150 minutes a week of walking or resistant exercise 3 times a week. We talked about the eye exam because we are really worried about microaneurysms, the cotton wool spots, and we talked about a foot exam as well. And we want to be pretty open about our goals of care with our patients. There are several complications that you will hope to avoid. You've got complications of the small vessels, microvascular complications, and those are things like your retinopathy, your neuropathy, nephropathy. Okay, you've also got macrovascular complications, and we know that people with diabetes have an increased risk for coronary artery disease, peripheral artery disease, stroke, and we do want to keep their blood pressures below 130/80, and that's an ANCC AHA guidelines. So make sure that you're being vigilant about this with your patients. I talked about how the importance of getting an annual fundoscopic exam with an ophthalmologist. And that's especially important for your diabetics because they can be at risk for visual changes. We know that if we see cotton wool spots, this can be an indicator for diabetes. And when you think about it, basically the cotton wool spots, it works the same. We talked about the retinopathy, the neuropathy. It's basically when the nerves are dying. So when the nerves die in the eye, they'll have these yellowish, white, fluffy spots. I have a picture of these 2 little girls eating the cotton candy because I think about cotton wool spots, diabetes. Okay, I want you to remember that. So if you do a fundoscopic exam and you see what you think are cotton wool spots, you want to definitely refer to optometry. This can also be a common eye finding with people with systemic lupus as well. So keep that in mind. Neuropathy is something that's pretty common with the diabetics as well. And basically, this is a gradual loss of the integrity of the longest nerve fibers. So you're going to find that these symptoms they're going to be found distally and symmetric. It's the most common complication. It's a major cause of morbidity. Why? They don't feel that they have an injury to their foot. They can get septic. They can have osteomyelitis that's not recognized. And it's really important that these patients get in with a podiatrist. What is some of the preventative care? Glycemic control. You want to keep them under good care. Annual podiatry visits. You want to make sure that their B12 levels are good. We know the first line drug is metformin for diabetes type 2, and that can cause those B12 levels to dip. You also want to make sure that you're doing a fall assessment on your elders. Okay. For diabetic neuropathy, the first-line pharmacotherapy is usually some antidepressants. You may use duloxetine, amitriptyline. They may use gabapentin. And so, you may be putting your patients on this for control of the pain because it can be quite significant. Once again, just remember foot injuries, you need to be vigilant. These patients need to wear white socks. They need to examine their feet after every bath, looking for any open areas and any type of drainage. And one time I remember doing a pre-op, or wasn't a pre-op, it was a pre-employment physical on a patient. And I saw her feet. It was summertime. She had flip-flops, so she had thrown her flip-flops off, and she's swinging her foot. And I saw something on the bottom of her foot. And honest to God, there was an open area that was the size of a $50, and it was full thickness. She had a huge diabetic ulcer that she had no idea was on the bottom of her foot. So it's really important that we as clinicians are taking a good look at the feet too when we see our patients. Talk a little bit about the treatment for diabetes. For type 1, we're often going to use our insulin. These patients are insulin dependent. You're going to be most likely partnering with an endocrinologist to manage them. Our type 2 patients, often we're going to use the oral medications, first line drug metformin. We may use insulin. We may use oral medications and insulin. For our gestational diabetes patients, we will usually use just insulin for them. So keep that in mind when we think about what do we treat our patients for diabetes with. This slide shows you the algorithms that are used to treat diabetes type 2. Now, before you freak out and you're like, oh my God, I'm never going to remember any of this, I want you to look at the very top line. Again, first line therapy for diabetes type 2 is metformin and comprehensive lifestyle modifications, okay, weight management, physical activity, and then you will move down the line. So in the next few slides, we're going to talk about some of the common meds that are used to treat diabetes type 2. Drugs that we do use to treat diabetes type 2. And there's several suffixes that you need to pay attention to because it will help you recognize which drugs are from what class. So the first one is the biganoide. That's metformin. Suffix is ide. This is the first line medication for type 2 diabetes. Why do we love metformin? Metformin because there's basically minimal to no hypoglycemia. Maximum daily dose is 2,000 per day. We often will start the patient off at 500 twice a day. And you can often see an A1C reduction by 1 to 2%. When is it contraindicated? It is contraindicated with an individual whose GFR is less than 45, someone who has acidosis, an alcoholic, a history of hypoxia, someone who's had active liver disease, heart failure. Okay. We do see an increase in B12 deficiency after they've been on the med for several years. It is okay to give metformin in someone who is in stage 1 heart failure. The risk of lactic acidosis is pretty rare, and we want to make sure that we hold if the patient is getting any IV contrast for 48 hours. So that's important to make sure we're educating our patients too. What are the side effects? These patients can get diarrhea, they can have flatulence, they can have some nausea. Your sulfonylureas, okay? These drugs stimulate Basal to secrete insulin. All right, with these patients, they have a hypoglycemic risk. Okay, so you need to make sure that you are talking to your patients about the signs and symptoms of hypoglycemia. There are some side effects with the sulfonylureas. They can get weight gain, they can have hypoglycemia that we talked about. And one thing, we do know that the price is a lot lower for these type of drugs. Your SGLT2 inhibitors, these end with Flozin, okay? This is your drugs. You've seen them on TV, your Invokana, your Jardiance, and I do recommend for these drugs that you Google some of the commercials because sometimes, watching the little video, their little things they talk about, you're going to learn an awful lot from the commercials. You think I'm nuts, but I do. That I'm going to have you challenge you. Take a picture of this screen and then Google Invokana and watch it, and you're going to see there's a lot of things that we talk about on this slide that are right in that commercial, okay, because they talk about some of the risk factors. So we know with the SGLT2 inhibitors, these are cardioprotective, they decrease coronary artery disease risks, they can cause that dehydration. You want to avoid them in patients that have frequent UTIs or incontinence, because this is going to make them really have some issues, using the bathroom frequently. And you do want to use caution if the patient is currently on a sulfonylurea, because that increases that hypoglycemia risk. All right, the next one would be your TZD. Now, this is an insulin sensitizer. It acts on fasting and postprandial sugars. There is very, very little hypoglycemia when used alone. These are your Avandia, your Actos. With these drugs, you want to make sure you monitor their liver function, their ALT, and you want to avoid in individuals with heart disease or CHF, okay, because this increases the edema and can exacerbate that CHF, okay. Your DPP4 inhibitors, gliptin, okay, this is your Januvia, okay. These patients, they can present with some joint pain. Again, you want to caution use concurrently with the sulfonylurea, because you can end up with some hypoglycemia as well. These drugs, they work, they increase the insulin release, and they act in response to an increased blood glucose post-meal. There isn't much hypoglycemia with these medications when they're used alone. And we talked about the joint aches, but they can also be at risk for pancreatitis too. These are pretty expensive as well. And then you've got your GLP-1 agonist. Okay, this is an injectable. So if your patient only wants pills, this isn't the drug for them. And these end with TIRED. These are your Ozempics, your Trulicity. These are found to be cardioprotective. They decrease coronary artery disease risks. They are contraindicated in patients who have had a history of pancreatitis or medullary thyroid disorder. You'll hear that repeatedly in the commercial. It was funny, somebody told me that a long time ago, that if you watch all these drug rep commercials, that you can get like 4 questions right on the board. So, next time you're paying attention to the news or watching whatever, just pay attention to them, because I'm sure you'll see one of these meds on being advertised. These meds, the GLP-1 agonists, they're injectable, they're expensive. You can see a A1C reduction of 1 to 1.5%. So they're really pretty popular now, because they also help patients lose weight. Insulin, there's a couple different ways that we give insulin, and there's a couple different types. So there's 2 different types, and specifically, that are basal and bolus. Okay, basal, these are long acting, and generally will get a 24-hour coverage. They will usually be dosed at night. This is your Levemir, your Lantus. You want to increase the basal insulin if the fasting blood sugar is elevated, okay? And how do we adjust it? Well, we're going to start them at a lower dose, and then we're going to increase the dose until they're controlled by 2 units every 2 to 3 days. Bolus insulin, this is short acting. This is your Humulog, Humulin-R, Novolog. This insulin needs frequent blood glucose checks, and when you're checking you're going to be checking their blood sugar, usually AC and HS, so after meals and at bedtime, and you're going to increase if after they eat, their postprandial blood sugar is elevated. Okay, how are you going to adjust it? You're going to adjust the insulin 1 to 2 units every 2 to 3 days until you get control. For you to understand the different onset of action, the peak, and the duration of different insulins. And this is just something, if you didn't memorize it when you were studying for your RN boards, you're just going to have to memorize it now. So short acting, onset after injection, is going to bring that sugar down, start bringing the sugar down in about 30 minutes. Okay. Peak is in an hour. Duration is 2 to 4 hours. Okay. So you're going to be seeing this given as a PRN or AC and HS with a sliding scale, perhaps. Rapid acting, this is your Novolog. Okay. Onset is 30 minutes, peak is 1 hour, duration is 3 to 6 hours, and again, this is given PRN, AC, and HS. Intermediate acting insulin, this is your NPH. Onset after injection is about 2 to 4 hours. The peak is within 4 to 12, and the duration is 16 to 24. This, keep in mind, NPH is the one that you need to make sure that you roll, and you want to always mix the insulin clear to cloudy, and often NPH is given twice a day. Long-acting, this is your Levemir, your Lantus. The onset after injection is 1 to 2 hours. The peak, there is none. Okay, and the duration is usually 19 to 24 hours. Some of the new meds are even longer than that. And that insulin is often given once a day. Educating your patient about insulin injection sites, it's important to know where they can get their insulin, where should they be injecting. So in this slide, you can see the shaded areas. These can be used for insulin injections. They should rotate their sites. And keep in mind, too, that insulin is absorbed more rapidly when injected into the abdomen as compared to the arms or the legs. Can be kind of tricky is how do you adjust the basal insulin? And I like this grid because it kind of breaks it down for you. So if the breakfast glucose is low, you are going to decrease the bedtime basal. If it's high, you're going to increase it. If the lunch glucose is low, you're going to decrease the breakfast bolus, or if it's high, you're going to increase that breakfast bolus. If your supper glucose is low, you're going to decrease the lunch bolus. And if it's high, you're going to increase that lunch bolus. At bedtime, if the glucose is low, you're going to decrease the evening dose. Or if it's high, you're going to increase it. And if overnight, if the glucose is low, you are going to decrease the bedtime basal or give a bedtime snack bolus. Things that you need to think about if your patient is having morning hyperglycemia, okay? So the time that you would need to check the blood glucose to differentiate between dawn and Somogy effect is 3 a.m., okay? So dawn phenomenon, they're going to have a high blood sugar at 3 o'clock in the morning, okay? What's going on? The normal morning growth hormone is increasing, their insulin levels are decreasing, and so it's decreasing the peripheral glucose uptake. So what do you do for this patient? Okay, you're going to increase that long-acting basal insulin at nighttime or adjust the timing to improve the control. The Somogy effect, this patient at 3 o'clock in the morning is going to be having hypoglycemia, okay? And basically what's happening is with these patients, they're having rebound hyperglycemia due to hypoglycemia during the night, okay? So at 3 o'clock in the morning, you're going to see that's when they're having this really low blood sugar. What are you going to do for this patient? How would you manage that? You're going to reduce the bedtime insulin or adjust the timing, and you're going to give this patient a snack before they go to bed. So that's the last thing I wanted to discuss in this short lecture, and I hope you enjoyed it, and hopefully we'll be talking soon.